Welcome to today's webinar. My name is Jose Francisco, Project Manager at the IAS-USA. Today's webinar will be the first part of the four-part IAS-USA webinar series on pain and addiction. Today's speaker, Dr. Jessica Merlin, will be going over chronic pain in people with HIV, an evidence-based practical approach. Welcome, Dr. Merlin.
Thank you. Okay, great. Thank you very much, everyone. And I apologize for the issues people have been having with Adobe Connect. I was also having the same issues, so I'm glad you were all able to make it on. Just to give you a little bit of background on me to give you a sense of where I'm coming from with this material. I'm an infectious disease physician and also a pain and palliative care physician, board certified also in addiction medicine. And so clinically, I run a chronic pain clinic that's embedded in an HIV patient-centered medical home in Orion White Clinic here at the University of Pittsburgh. And previously doing similar work at the University of Alabama at Birmingham. And I do research in this space as well. So have been doing this work for in the clinic for about 8 years now. And so I'm in the trenches with you. I'm really excited to have this discussion with you today about an evidence-based practical approach to chronic pain in people with HIV. So going to hopefully, sorry guys, I'm having an issue with my mouse today for some reason. There we go. Okay, so just some introductory information. This is about your CME credit. And some additional information about nursing and pharmacy credits. You should be able to find this on the website as well. Here's some information about grant support for this webinar. And just to let you know that you'll be seeing poll questions from time to time, and then everybody's responses will be summarized at the end. Oh, and I'm sorry, and to ask questions, please type the questions in the chat box. Some of the IAS staff, IAS-USA staff will be monitoring the chat box and kind of summarizing comments for me to answer, questions for me to answer at the end. If I happen to seem like they're timely in the talk, I will also try to address them as we go along if I can. All right, here's your first poll question. Where are you joining us from? Great. So we have pretty good representation throughout the U.S. and even some representation in Europe and Africa. So thank you very much for such widespread support for this webinar. Fantastic. And if you could rate your level of experience in the medical management of HIV. Great. So all across the board, but skewing a little bit towards more expert. Excellent. Right. Well, we welcome everybody from all areas of expertise or all levels of expertise to this meeting. Great. Let's see. There we go. All right. So today our objectives are to describe the elements of an initial pain education conversation with a patient who has HIV and chronic pain, and then identify at least 3 evidence-based approaches you can actually use to treat chronic pain in the people with HIV in your practice. So we're just going to have some pretest questions. So this one says, what strategy is recommended when monitoring and managing patients with HIV infection on long-term opioid therapy? And I have to apologize for those not in the U.S. Response C is a little bit U.S.-centric. Okay, great. Looks like we can move on to the next question. Which of the following has been shown to increase the risk of opioids when prescribed? All right. This question looks to be generating a little bit of controversy. That's good. We will, by the end of this, you'll know the answers to both of those questions and lots more. So, okay, great. So, just to put us all on the same page, I'm going to start off by defining chronic pain. So there are varied definitions. Usually we think about chronic pain as pain that lasts for at least 3 or 6 months beyond a period of normal tissue healing. So, and some people would say pain that occurs on at least half the days for at least 6 months. So some idea of duration here, right? And that's really all it is, just pain that lasts for a long time. And just to make sure we're talking about some of the same things, common examples like chronic low back pain, other regional musculoskeletal pain syndromes, so like knee pain, shoulder pain. Sometimes people have something that we call chronic widespread pain, which is pain on both sides of the body, pain in the axial skeleton, and pain above and below the diaphragm. And a subset of that is something called fibromyalgia, where people kind of generally feel fluish, have pain all over, and also have other somatic symptoms, headaches, and peripheral neuropathy. And chronic pain is really common in the general population. I apologize, I meant to update this citation. There's actually a CDC MMWR that from 2018 that suggests that about 20% of people in the U.S. have chronic pain, and about 8% of people have what we would call high-impact chronic pain, which is just pain that significantly impacts people's quality of life. So this is a really common problem, and I realize that when I'm giving a talk like this, there are probably people in this room who have high-impact chronic pain or have close family or friends with high-impact chronic pain. It's an incredibly common issue. Sorry, having some mouse issues here. There we go. So chronic pain has a unique neurologic basis, and I bring this up because sometimes I'll hear people say chronic pain is a mysterious condition, and we don't really know what causes it. And I think when we tell our patients that, it kind of might make them feel as though we don't really know what to do with them. And it turns out that actually, there's a whole field of science that studies the neurobiologic basis of chronic pain. I'm going to give you 2 concepts that I think will help in how you think about this and how you discuss chronic pain with your patients. So one is called peripheral sensitization, whereby there was some kind of initial peripheral insult. So maybe somebody had a surgery or an initial injury in the periphery. And those peripheral receptors get hypersensitized even when that initial injury or trauma is gone, and that causes pain to persist. The other is called central sensitization, which is where you have no inflammation or trauma or injury in the periphery, but the brain continues to get this strong signal of pain. So a classic example of that would be something like fibromyalgia, right? We think of most chronic pain as having some components of both. And so when you're thinking about how to treat people with chronic pain, it's really important to think about treating both of these things. Chronic pain is heavily influenced by biological, psychological, and social factors. So it turns out that central sensitization that we just talked about, the pathways in the brain that control that are the same pathways that control mood. And so this is why we often not only we try to always screen people who have chronic pain for depression and anxiety, but really make sure that we treat it when it's there. Because it's important to treat in and of itself, and because we think that it helps people's chronic pain improve as well. And when I talk to people about this, sometimes what I say is, I don't know if you ever noticed this, but sometimes people will say when they feel down, it makes their pain worse, and when their pain is worse, it makes them feel more down, and they get into this cycle. Has that ever happened to you? And most people that I talk to are actually, even if they don't actually have depression or they don't actually have anxiety disorder, they can reflect in their experiences on this and understand this phenomenon. Social factors, so just thinking about the fact that chronic pain is extremely socially isolating, and that social isolation can actually make chronic pain worse. So I think a really important concept is that we think about chronic pain not as just a symptom of something else. So I know the way that I was trained was pain is a symptom of something going on, and we have to get to the bottom of what that something is. But sometimes chronic pain is just chronic pain. It's a disease in and of itself. It's not to say one shouldn't do a diagnostic workup and try to understand what physical factors may be contributing to it, but really thinking of the chronic pain as a disease in and of itself that's associated with substantial disability and can be really difficult to treat, which is what we're going to talk about today. So we're going to talk now specifically about chronic pain in people with HIV. We're going to go through the evidence base that exists about epidemiology, pathophysiology, and treatment. And then we're going to talk about a practical approach to implementing these evidence-based strategies. And because the literature on chronic pain and HIV is fairly limited, we're also going to draw from literature from the general population. And then we'll talk about a few hot topics in chronic pain management. So the evidence base. So as you may know, as I'm sure you know, neuropathic pain is what's been classically described in people with HIV, right, due to the virus itself, due to comorbidities like alcohol use or diabetes that cause neuropathic pain, due to old drugs that we don't use anymore but have a lifetime side effect of neuropathic pain. But more recent studies have shown a predominance actually of musculoskeletal pain. Neuropathic pain is still there, but in this one study of a large HIV primary care clinic, they found that 39% of patients had an ICD code consistent with musculoskeletal pain. And then there have been a few studies of clinics, including my own, when I was at the University of Alabama at Birmingham, where people with HIV are seeking treatment for chronic pain. And the most common reasons for seeking treatment in a clinic like that are low back pain and peripheral neuropathy. Multi-site pain is also really common. I think this is important to keep in mind because, it's probably the less common patient that comes to us who just has knee pain or just has back pain. People often have more than one location of pain. So in one study from the REACH cohort at UCSF, they found a median number of locations of pain of 5. In Phoenix, which is a large national HIV primary care clinic-based cohort, we found the median number of locations of pain to be 3. So that's all to say that these are folks who have really complicated chronic pain challenges. So I want to make the argument to you in this talk that chronic pain is a really important comorbidity in people with HIV. So when you're thinking about, your problem list and all the things that you want to address in your visits, and you've got, HIV, and you've got STD screening, and you've got the person's hypertension and diabetes and all these other things, I really want you to think about where chronic pain fits into that and why it's such an important comorbidity in this population. So the first reason is prevalence. So there are no directly comparative studies comparing people with HIV to the general population, but the existing studies suggest in people with HIV suggest prevalence anywhere between 30 and 85%, which is an impossibly large range and represents lots of different types of populations of people with HIV. The 85% comes from the REACH cohort at UCSF, which recruits predominantly from homeless shelters and soup kitchens, and the 30% comes from cohorts like CNICs, which are of folks who are primarily engaged in care and doing well, but you can see that those numbers seem to be generally higher than the 20% number I gave for the general population earlier. And then the impact on outcomes, which is sometimes limited by methods. The HIV cohorts that include questions about pain, oftentimes they're just asking, do you have pain today, or things like that. But from some preliminary cross-sectional studies, we know that it looks like chronic pain impacts retention in HIV, primary care, function, healthcare utilization, can lead to suboptimal ART adherence, and has been associated with the use of heroin and poor patient-provider engagement. So I would argue that it's for these reasons that chronic pain is really important in this population. So I mentioned a second ago that some of the studies of chronic pain in HIV have been limited by the types of questions we ask about pain, and so we did this study to try to address that concern. So we did a prospective study of chronic pain and HIV outcomes in CNICS, which is a cohort I mentioned a moment ago, national HIV cohort in the U.S. And we had a particular interest in the interaction between pain, opioids, and outcomes. And let me tell you why. So there's some literature suggesting that in opioid prescribing in people with HIV goals might supersede more conservative opioid prescribing that, as you probably know, and we'll get into a lot later, is really the best evidence-based approach, right? We know that opioids are not the panacea for chronic pain that we once acted as if they were. And so, so it seems as though people might think about the patient's HIV goals more than the risk of opioids. For example, and this is from a qualitative paper that a colleague of mine, Joanna Sterles, and I worked on, and this is of HIV providers in the Bronx, in New York, in the United States, and this one HIV provider said, in the HIV population, sometimes I feel like the opioids are used as a way to bring them in, to have them come back to each session so you can build their trust and eventually get them onto their heart. And this other provider said, by prescribing opiates, you may be increasing your chances of having them remain in your care so that they could benefit from actually having their HIV treated. And in this final quote, you make a deal that I will continue to write these medications for you, and I will do it reliably once a month, but I have to see you and we have to talk about your ART. I think many patients have gotten improvement in their HIV symptom control because of frequent interaction with the medical system. And so this perception that prescribing people opioids kind of keeps them on the hook and coming back into the clinic and sort of potentially minimizing potential adverse consequences of long-term opioid therapy. So we really wanted to look at this in a big national HIV cohort in the U.S. to try to understand, is it true that retention in care is connected to opioid prescribing? So we used 5 HIV primary care clinics to collect data within CNICS, and we looked at basically a year's worth of data. We administered pain patient-reported outcome measures where we asked people not just about pain today or something like that, but about pain in the last 3 months, or pain that is greater than the last 3 months. And we also asked about pain severity. And we were able to also determine whether somebody was on long-term opioid therapy. So having chronic pain and being prescribed long-term opioid therapy were the independent variables. And the outcome variables were suboptimal retention in HIV primary care and also virologic failure, of course, always an important outcome. So this was a very large study, I think, by HIV standards, so over 2,000 participants. And in this study, we found that 25% of people had chronic pain, and 19% of all participants were prescribed long-term opioid therapy. And then just like is typical in clinic-based cohorts of people with HIV, suboptimal retention in 27%, virologic failure in 12%. So a pretty well-connected and healthy cohort of people with HIV. So our first finding was that we found that among individuals who were not on long-term opioid therapy, that chronic pain was associated with increased odds of suboptimal retention. So again, I told you earlier that I was going to try to convince you that chronic pain in and of itself is a really important comorbidity in HIV, and I think that this drives that point home, and also increased odds of virologic failure. So then we also looked at this question about opioid prescribing. So we looked at individuals with chronic pain and found no association between long-term opioid therapy and retention in HIV primary care. So if people are trying to prescribe opioids to keep people retained in care, it doesn't seem as though it's working. However, we found that long-term opioid therapy, interestingly, was associated with lower rates of virologic failure, which was an unexpected but very interesting finding. Sorry, guys, my mouse is really acting up and doesn't want to let me advance. There we go. So I think what this study shows us is it really reinforces the need to identify effective chronic pain treatments, because this is clearly an important comorbidity. It's something that we should be addressing, and really think about the impact of these pain treatments on HIV outcomes. It does not seem that long-term opioid therapy is protective against suboptimal retention, and then this kind of odd apparent protective association between long-term opioid therapy and virologic failure, which I think is just hypothesis generating and merits some additional explanation, right? Because this has brought up the question, is there something biological going on here? Is it just that people who are prescribed opioids have made a deal with their providers that they're going to take their HIV meds if they get prescribed opioids, and that's the reason that opioids seem to be protective against virologic failure? I don't think we know, but we have better ways to help people sustain their virologic suppression than prescribing them opioids. So that's clearly not the take-home point of this. All right. So one fundamental question that comes up a lot is, why do people with HIV have such a high burden of chronic pain, right? And there are two main hypotheses in the field. One is some kind of biological mechanism. And, one could think about, for example, inflammation that is present in people with HIV, right, even when they're fully virologically suppressed, and is that driving chronic pain in some way? And then, another hypothesis would be that chronic pain is highly comorbid with mental illness and addiction. HIV is highly comorbid with mental illness and addiction. Maybe it's just a function of that we see so much chronic pain in HIV. So this prompted us to take a look at pain pathophysiology in people living with HIV. And this is just an example of one of our studies where we take people into a pain lab and subject them to standardized levels of pain in an ethics and institutional review board approved way. I've actually been through these protocols. They are not that bad. So basically, this is one where we subject people to heat pain, so just thermode with standardized levels of heat. And what we find is that when you compare people with HIV who have, I'm going to try to use the pointy here, detectable viral loads here at the top versus undetectable viral loads versus controls, the people with the detectable viral loads have the most pain sensitivity. In other words, when you apply this thermode to their skin, they say that it hurts faster than people who have HIV who have undetectable viral loads, and even more so than controls. So that's just a suggestion that the HIV virus itself is playing some kind of role with regard to pain sensitivity. I'm going to take my pointer away. There we go. So as I mentioned a moment ago, it seems reasonable to wonder whether inflammation might contribute to pain in people with HIV. And in fact, we've looked at this. So this is a study we published in JADE a few years ago, where we found that levels of IL-1 beta differed between people who had chronic widespread pain and people without pain who have HIV. So this is, again, just to show you that people are thinking about the biological mechanisms that may be occurring in people with HIV perpetuating their chronic pain. All right, on to treatment. So why address chronic pain treatment separately in people with HIV? So there are a couple of reasons for this. One is pain biology. There may be differences in pain biology, and so, I just mentioned a few studies that suggest that. The other is the psychosocial milieu, right? I don't probably have to explain this very clearly to this audience, but people with HIV suffer from stigma, they suffer from social isolation, and these things are also true of people with chronic pain, so it makes one wonder whether the psychosocial milieu would require treatments for chronic pain that are a little different in this population and in the general population. And also, I can speak to the U.S. for this treatment setting, so HIV care is often provided in Ryan White clinics, patient-centered medical homes for people with HIV, which have particular implications for scaling of evidence-based treatments for chronic pain in this population. And, as I mentioned a moment ago, there's a relationship between chronic pain and HIV outcomes, and so one would imagine that treating chronic pain in this population might actually improve these HIV outcomes, and that's something, obviously, to specifically consider in people with HIV. So, given how important chronic pain is as a comorbidity in this population, one would think that there have been lots of interventions studied, and there's lots of literature on this. So we did a systematic review on this in 2016, and I can tell you that there have only been a few studies published since then that would have made it into this review, one of which I'm going to show you. But basically what we found is only 11 studies of interventions for chronic pain and HIV, mostly of low or very low quality. 7 pharmacologic and 4 non-pharmacologic interventions, and of the pharmacologic interventions, 2 were cognitive behavioral therapy, 1 was hypnosis, 1 was cannabis. The only controlled studies with positive results were capsaicin and cannabis, but both had extremely short-term follow-up. And of the 7 pharmacologic interventions, 5 had substantial pharmaceutical industry sponsorship, raising concerns certainly about potential bias. So to sum it up, there's really just not a lot out there. So this is a really important area for research. What kind of interventions are needed? So I told you before that we were going to have to look to the general chronic pain literature to really help us understand what some of the best evidence-based treatments are for chronic pain in people with HIV. And so when you look at the general literature, really behavioral interventions stand out. So behavioral interventions were highlighted in the US CDC opioid prescribing guideline that came out a few years ago as a really important component of chronic pain treatment. The US National Pain Strategy, which also came out a few years ago but still is a driving document in the field, mentioned a particular type of behavioral intervention called pain self-management, which we'll talk about more in a second, 24 times. You can do a little find and count, just to give you a sense of how important this field thinks it is to focus on pain self-management interventions, behavioral interventions in general, and specifically pain self-management interventions. Pain self-management interventions are based on cognitive behavioral therapy, and they're basically manualized versions of cognitive behavioral therapy that could be delivered by a clinic staff member, like a nurse or a social worker who has good communication skills, who can help people work on the typical things that we find in cognitive behavioral therapy, essentially reframing thoughts about people's chronic pain, learning how to do normal activities despite having chronic pain, setting goals related to chronic pain, etc. And then thinking about what exists with regard to behavioral interventions for people with HIV. So there have been 3 studies of psychologist-delivered CBT or behavioral activation therapy, so not pain self-management, but full-blown CBT delivered by a psychologist, which raises a lot of questions about feasibility. There have been some studies of mindfulness. All of these have been pilot trials. None of them have really involved work to tailor the interventions to people with HIV, and we talked a moment ago about why that might be important. And having these interventions be delivered by a psychologist really raises questions about feasibility across HIV settings and access to these types of interventions. So this prompted us to develop a pain self-management intervention for chronic pain that's really tailored to people living with HIV. And actually, I'm sorry, I should back up and say, so not only were all of these pilot trials, but they also suffered from pretty poor adherence. In the psychologist-delivered CBT studies, people were only coming about half the time. So it makes it difficult to have success with that. So at any rate, so we developed an intervention called Skills to Manage Pain, or STOMP. And the way that we developed this intervention was really to talk to patients with HIV, talk to HIV primary care providers, and really figure out what the needs were that were specific to this population. And what we found was that people really felt like it was important to hear from a peer who has HIV and chronic pain and is doing fairly well. And they felt that it was important to have this intervention delivered in a group setting to basically build some social support around their chronic pain and also to kind of share tips and tricks with other people going through the same thing. And there was clear consensus that having both this group component but also a one-on-one component with a staff interventionist who could go through some of these typical kind of one-on-one sessions that are really common in pain self-management interventions, like how to communicate about your pain, some cognitive restructuring sessions, how to have better sleep to have better pain, physical activity and pain, that sort of thing. So we conducted a pilot trial of this intervention versus usual care, and we showed feasibility, acceptability, and some suggestion of preliminary efficacy, and we currently have an R01 to do a full-scale efficacy trial of this intervention. So I'm happy to share the materials from this intervention if folks are interested. But I think that these types of interventions have real promise in our patient population. All right, so now that we've thoroughly gone through the evidence base on this topic, now we're going to talk about what to actually do in clinic, okay? So history and screening. So we've all, regardless of what our background is as a clinician, learned how to do a pain assessment. Really, the most useful thing is to try to understand the impact of pain on function. So not just pain on a scale of 0 to 10, what makes it worse, what makes it better, all those typical things we learn in school, but how does pain impact, for example, their general activity or their enjoyment of life? So there's a questionnaire called the PEG that actually asks those 3 questions: pain severity and the impact of pain on enjoyment of life and general activities. We use that questionnaire in our clinic every time somebody comes in so that we can track it over time. The other question that I find really helpful is just asking people how to spend their time, how they spend their time, because it's a very different person with chronic pain. Even if somebody has 10 out of 10 pain, it's a very different person with 10 out of 10 pain that spends all day in bed versus somebody who's working a full-time job, right? So it's helpful to get that baseline level of activity. You want to understand their pain management history, getting records if possible so that you don't reinvent the wheel, and you can also try to understand some of the challenges that the patient has encountered in the past with pain management. You want to screen for things that are common in chronic pain so you don't miss them. So highly recommend screening everybody for depression using the PHQ and anxiety using the GAD or whatever instrument is feasible where you're working. Screening for substance use. So chronic pain and substance use are highly comorbid. Don't forget about alcohol, because I think we forget about alcohol. And I've listed here a quick way to do this. The night a quick screen is a great way to do this. And I always ask people about sleep problems because we know that when people aren't sleeping well, it makes their pain worse during the day. And so if we can address a sleep problem, we can usually help with their pain as well. Okay, great. The other thing that I like to talk to people about is their coping and self-management strategies. So, and this is something that as you build a relationship with someone over time and you talk to somebody about their chronic pain, you tend to kind of pick up on. So this little guy has painted himself into a corner, and of course there's no medication that's going to help him walk out that door. So, you know, when I think about coping strategies, I think about things like catastrophizing, where somebody might say, you know, I have fibromyalgia and I'm convinced I'm going to be in a wheelchair, or something that we call fear avoidance, which means somebody is avoiding physical activity to avoid exacerbating their pain. Both of these things have been associated with worse outcomes. So just trying to note these things, and also noting positive self-management strategies, like somebody who says, well, you know, I'm really active in this social group, and when I'm socializing with them, I actually don't think about my pain as much, you know. And most people can identify strategies that they use in their daily life. Diagnostic testing. So the purpose of this talk is not to give an exhaustive review of all types of chronic pain and all diagnostic testing you might do, but just to give you some overall guidance, which is that evidence-based judicious use is best. So I frequently get people sent to me who have had hand body scans and, God forbid, Lyme serologies and, you know, whatever else, and you really don't want to do that, right? What you want to do is think, okay, this person has, for example, low back pain. So you can go on UpToDate, you know, and look to see what are the evidence-based approaches to a diagnostic workup of chronic low back pain, and you find that actually most times imaging is not indicated. And so, you know, just thinking things through from an evidence-based perspective like that, and realizing that you can't always see pain on an image or blood test. I know that may seem obvious, but if you think about that for a second, we don't act that way, right? We act like if you don't see it on the image, either the person doesn't really have pain, or if you see it on, you know, if the person has, you know, really severe DJD on their spinal MRI, they must have really severe pain. And we know from imaging research that that's not the case, actually, that, you know, if you MRI 100 people in the general population who don't have chronic pain and then people who do have chronic pain, overall their MRIs look really similar. So pain often does not correlate with some kind of biological finding on an image or on a blood test. And this is, you know, it's a challenge for us as clinicians, or I'll speak for myself, for me as a clinician, because I was trained to look, you know, look for like the smoking gun always. And patients want this too, right? And so this just becomes kind of an important communication challenge to make sure you explain to your patients that we don't see it on a blood test or on an imaging study, but I believe you, you have chronic pain and there are things we can do to help you. So speaking of communication challenges, just kind of want to put it out there that communicating about chronic pain can be really challenging. So, you know, patients can come with baggage, right? So patients might have had experience with other providers where they're told that they don't really have pain, or the pain is all in their head, or that they're just seeking opioids. And providers come with baggage too, right? We've all taken care of patients who have chronic pain that may have really challenged us in certain ways. And sometimes in conversations with patients about chronic pain, opioids become the focus rather than functional restoration, right? Rather than getting the patient better. We're not trained to do this, right? I mean, despite, you know, 2 fellowships and a lot of years of doing this in practice, most people I've received very little formal education, or come across very little formal education in how to take care of patients with chronic pain. And the other thing is that we have a financial incentive to take a biomedical approach, right? We can just write a prescription or write a script for an MRI. That's much easier to do than to really sit down and have a conversation with a patient about all these things. Commonly used medications have limited evidence base and carry risk. Patients might have mood disorders or addiction that color the way they communicate. And the best treatments, like pain self-management, are often inaccessible to patients, right? When you think about things that do have evidence base, not only pain self-management, but things like acupuncture, physical therapy, it's often hard to get people to those therapies. But don't despair, there are lots of things you can do. So remember, first, do no harm. Focus on evidence-based treatments and avoid unnecessary procedures, surgeries, and medications. So it's not uncommon. I'll see somebody who's had 5 surgeries for their low back pain, but their depression has never been addressed. So you really want to try to avoid that. You want to set concrete goals and timelines. So if you are going to start a new medication on somebody, you want to say, we're going to start it. We might go up on the dose over this period of time, but if it doesn't work, we're going to stop it because you don't need a medication that can just cause you side effects that isn't working. And if possible, treat psychiatric illness first. There's no randomized trial of treating psychiatric illness first versus not, but it stands to reason that, depression can make pain a whole lot worse. If you treat somebody's depression, their pain may actually kind of fade away into the background. So you really want to make sure to do that. I'm not going to spend a lot of time on this, but these are great resources. So motivational interviewing and cognitive behavioral therapy are incredibly useful tools to have in your toolbox. You don't need to be an expert in either of these to just pull out a couple of tools. So these are 2 books that I really like. The one on the left is a CBT self-help manual that when I have patients who have very high literacy levels, I often recommend, and that they can go through it themselves. And I've read it, and I use strategies from this book with my patients sometimes, and motivational interviewing, because really what you're asking people with chronic pain to do, right, is to change their behavior. You're asking them to be more physically active, to, be able to participate more in life despite having chronic pain. All right, pain education. So when I first meet somebody with chronic pain in my practice, I talk about what chronic pain is. I even talk about peripheral and central sensitization. I don't necessarily call it that, but I want people to understand that there's a biological basis for their pain that we understand. I talk about patience, so that I understand that they wish this would go away yesterday, and I wish that for them too. They didn't get here overnight. This isn't going to go away overnight, but with partnership and collaboration, I have a lot of confidence that we can get things better so that their pain can be in the background and they can do the things that they like to do. I talk right from the outset about how we use both pharmacologic and non-pharmacologic management. I utilize multiple team members, so I've assembled a multidisciplinary team in my clinic that includes an amazing pharmacist, physical therapist actually sees patients with me, and then we have wonderful psychology staff in our clinic that we collaborate with closely. And I talk about members of all of our team members when I meet people, so that folks understand that this is going to be a multidimensional process. I talk about mind-body connection, so I help people make that connection between their pain and their mood, for example, so that when I start talking about medications that are antidepressants, for example, like duloxetine, that it, makes sense. And then I really emphasize functional goals, not so much how severe somebody's pain is, but what they can do or what they wish they could do if their pain were better, so to think about how to get them there. So you want to consider both pharmacologic and non-pharmacologic therapy. So there are lots of non-opioid pharmacologic therapies that you can use, right? I'm not going to go through this in a lot of depth, but just remember that muscle relaxants and benzodiazepines are not evidence-based treatments for chronic pain. Non-pharmacologic therapies, I've listed the ones here that have evidence behind them, most of which I've already mentioned. And again, really making sure that people understand that interdisciplinary and multimodal care is how we manage chronic pain. And that oftentimes a combination, there'll be some trial and error in a combination of some of these strategies, depending on what their interests are and what they have access to, is really what's going to help them. Okay, so now I'm going to talk about opioids. We have probably about 10 to 15 minutes to do this. So opioid prescribing in the U.S. is still a really big challenge, right? So in 2017, 17% of the U.S. population received an opioid prescription, and overdose deaths increased 90% between 2013 and 2017. So people are still using a lot of opioids for chronic pain. And while it is true that a lot of overdose deaths are related to heroin, in 2017, still 36% of overdose deaths were due to prescribed opioids. And the other thing to keep in mind is that if people who actually have an opioid use disorder, very few actually receive treatment. So this is really, really important, right? So I'm taking a look at some of the questions coming in, and so I'm going to breeze by a couple of things that I think are of less interest, and that way I can spend a little bit more time on things that are of more interest. So these are some things that I already covered a little bit that you can look at on your own. So one of the questions that often comes up is, so, you know, in 2020, what do we think about opioids with chronic pain, right? What is the, and I'm going to show you some of the studies in a second, but what is the approach to considering opioids in chronic pain? So if somebody is not currently receiving opioid therapy, the recommendation is to avoid opioids. So this was published in JAMA about a year ago or so. It's a great paper that kind of walks you through this. But and the other thing too is that a lot of these risk stratification tools that we might use to determine whether somebody is high or medium or low risk for opioid prescribing are actually no better than the flip of a coin. So these are things like the opioid risk tool or the SOAP or the DIAR. So really, if somebody has chronic pain, we should be avoiding opioid therapy in most cases. The bigger challenge, I think, is people have chronic pain who are already receiving opioid therapy, and for them, you want to not just taper or discontinue them willy-nilly, but really think about, with the patient in a patient-centered way, what benefits are you getting from the opioids? What harms are you experiencing, if any, from the opioids? If you're on a high dose, which has been associated with increased mortality, you're on benzodiazepines also, which has been associated with increased mortality, should we consider tapering you or switching you to a safer opioid like buprenorphine as a way of mitigating your long-term risk? And then for acute pain, really courses should be limited to less than a week and avoided if possible. So why is this the approach? So here are all the harms that have been associated with long-term opioid therapy: decreased function, return to work, depression, motor vehicle accidents, falls, opioid use disorder. So the rates here, probably around 10% of people who are prescribed opioids develop an opioid use disorder, but you can see the rates vary pretty widely depending on the setting. And then overdose mortality, which I already mentioned is worse with high-dose opioids greater than 100 milligram equivalents of morphine a day, co-prescription of benzodiazepines, Epipennoids, and this also includes tramadol. So a lot of people think tramadol is a safer opioid, but there's evidence coming out that it isn't. So in terms of the benefits of opioids, so systematic reviews and meta-analyses have really identified few high-quality and no long-term trials, small improvements in pain intensity with opioids, and really kind of a questionable improvement in function. It looks like, based on especially one prospective randomized trial, which is the Krebs citation there, that outcomes may actually be better with NSAIDs and antidepressants, and clear evidence of harm in a lot of these trials. So when would you start somebody on opioids? So you've done everything else. Pain is really adversely affecting function. Benefits, you think that the benefits outweigh the harms. You've really discussed this in depth with the patient, and maybe you've done a risk assessment. So I usually don't get to the bottom of this list. I usually find that, you know, I can help manage somebody's pain way before I get to the bottom of this list and really would need to think about an opioid. So as I mentioned a moment ago, the traditional tools that we've used to predict opioid risk really don't do a very good job. And so the more recent approach has been to think about factors that are predictive of high opioid use disorder risk in general. So somebody has a history of opioid use disorder, another substance use disorder, certain mental health diagnoses, are on certain psychiatric medications, you might want to especially think twice about opioids. You're already thinking twice or three times because you know that they're not that effective. But so while we can identify certain high-risk individuals in that way, there really are no symptom-centered tools that can identify low-risk individuals. So there's really nobody for whom you can say, this person's going to be fine on opioids 100%, I know it. So to sum it up for long-term opioid therapy, there's lack of evidence of benefit, significant evidence of harm. And the conventional clinical wisdom is that, and I subscribe to this, is that, some people, of course, do experience some benefit from opioids. The problem is it's so hard to determine who those people are going to be when you write that first prescription. So yeah. If you do prescribe opioids for somebody, and usually this is somebody who has probably been on opioids for a long time and you're maybe continuing them, there are a few strategies that we use. We take a universal precautions approach to this type of monitoring. Everybody gets the same thing: regular visits, opioid treatment agreements, urine drug testing, and prescription monitoring program. The other thing that we want to do is to identify opioid misuse behaviors. So these are behaviors like missing appointments, taking opioids for symptoms other than pain, using more opioids than prescribed, aggressive behavior, alcohol and other substance use. And I've listed here in blue ways that you might find these behaviors, whether they're in your clinical interview or in the EMR. And there are actually management algorithms, which I'm not going to go into here. That's probably a long separate talk, but they're on this website, mytopcare.org. They've been published there for how to think about what to do with these behaviors. And essentially, the bottom line is you don't want to just cut somebody off of their opioids because they have one of these behaviors. You want to monitor them, look for whether or not there's a pattern of behavior, look for whether or not there's an opioid use disorder. So opioid tapering, this is a question that comes up often. I'm happy to talk about it more in the Q&A. Anybody on long-term opioid therapy should probably be considered for a taper, meaning that it should be a conversation with the patient. When you were started on these medicines, our understanding of their benefits and harms was really different. And so here's what we know now. Let's look at whether or not they're really helping your pain, helping your function. Let's look at whether you're on a high dose or you're co-prescribed a medicine that might increase your risk of harm. There is a great systematic review that Joe Frank wrote in 2017 that suggests that voluntary tapers result in the same or reduced pain and no change in function. And so I often will bring this up to people. Somebody is asking in the chat about switching to buprenorphine instead of full agonist opioids for pain, and I started in my practice to do this to offer this to everyone. When I have this discussion about tapering, it's tapering and or a switch to buprenorphine with the explanation that, buprenorphine overdose is extremely rare. It's a much safer opioid. Its harms have a ceiling effect, and so you're much less likely to accidentally overdose on it. So that's a conversation I have a lot in my clinic. And there are, I put this here mostly so you'll have the citations for this. There are opioid tapering protocols out there that are essentially, the idea is to be very patient-centered. So to the degree that you can, let the patients make the decisions about exactly how the taper is going to happen. Don't worry about it happening on any particular timetable. It may be infinitesimally slow, and that's okay. So I'll leave those citations there for you. And this is another great paper about kind of how to consider patient-centered reduction or discontinuation of opioids. And you can see, to answer the question that just came up a minute ago, this is a flow chart that is in that paper. And you can see that it's all about you're assessing benefits and risks. The risks outweigh benefits, then taper down until they don't. If the benefits outweigh risks, keep prescribing. If you're having trouble, you want to consider buprenorphine, and you might even want to consider buprenorphine up here. Okay. So buprenorphine entering into the discussion is becoming a more widely accepted practice. Okay. Hot topics. So we just sort of kind of covered this. I will say you really want to be attuned to whether the patient might have an opioid use disorder, right? So if the patient is having opioid misuse behaviors, especially you're asking them questions about craving. You're asking them questions about that might indicate loss of control, right? If somebody has an opioid use disorder, you think it's likely that they do, then those are people that would we would switch to buprenorphine. Sometimes I find myself really scratching my head and saying, does this person really have an opioid use disorder or not? They're kind of on the borderline. Yeah, they're overtaking their medications, but they seem to be making all of their appointments, and it seems like, you know, they're really apologetic about missing all of their medications, and maybe, you know, maybe everything that they're saying really explains why. But there's no harm really in switching people to buprenorphine. It's a safer opioid, and if the person's not really taking the medication safely, you could just do it on those grounds alone. And then we already talked about kind of these categories of kind of lower threshold for switching to bupe. I put this in here so that you have it. These are newer approaches to buprenorphine induction. I don't know how much experience the group has with buprenorphine, but it used to be you had to stop somebody's full agonist opioids completely, make them go into withdrawal, and then start their buprenorphine. But there is now an approach called microdosing where you overlap the two and can do that safely. And this is actually from Annals from this year, where Will Becker published this beautiful table of exactly how he has done this. And now I have used this on several patients using buprenorphine in the outpatient setting to switching people with chronic pain over using microdosing. Because of the questions I see coming in, I'm going to skip these slides. And I want to, we already mentioned this association between Epipennoids and mortality in people who are co-prescribed opioids. I thought, sorry, it might have gotten cut off. I thought I had a couple of, well, actually, it's because we have a whole talk on cannabis. Sorry. That's why I deleted my cannabis slides, because we have a whole talk on cannabis. I see a lot of questions related to cannabis. So just, I hope you guys will attend the talk on cannabis, which is coming up. Jose can give us the exact date, but there's no evidence for CBD. There are no studies of CBD. The literature on CBD for pain is very thin, and so there's really not an evidence base for that. In terms of cannabis itself, so the bottom line is that the best evidence for cannabis in patients with chronic pain is for neuropathic pain. But even in patients with neuropathic pain, that evidence comes from a meta-analysis of 11 studies, which really have equivocal results. So, and the problem is that when you send somebody to a dispensary, you don't necessarily know what's happening there. And that varies from state to state. So there are states where the dispensaries are more likely to communicate with you, and you might be able to really talk to the pharmacist and you know, work with them to make sure that they're going slowly and talk to them about the patient's comorbidities. But there are other states or dispensaries where that's going to be less likely. And so I just really caution you to think about what happens when the patient walks out of your office and into the dispensary, and how that dispensary is helping people make decisions. All right. I'm going to ask Jose to pop in with the summaries of additional questions that people have. Oh, actually, you know what? I'm sorry. I'm going to do that. I guess, Jose, I need to do the post-test questions first. Sorry. Okay. All right, guys. Let's do the post-test questions, and then we will take questions from the audience. Sorry about that. These are just the same as the pre-test questions. I'll let you take a look. Great. All right. Excellent. So people got this one right mostly. So practitioner database monitoring programs. The reason why these other ones are not correct is, yes, opioid treatment agreements can be an important part of opioid risk mitigation, but they're not legally binding contracts. They're basically informed consent documents. Urine drug testing is important. We didn't actually talk about the exact frequency, but usually the recommendation is once a year, more frequently if there is a specific concern. So, and I said it so many times, so thankfully nobody chose D, which is immediate discontinuation of opioids, usually not recommended. All right, can give your answer to this next question. Great. So most people got A and B, and we talked about the cycle length during the presentation. All right, great. So now I'm going to take additional questions. I think we have probably about 10 to 15 minutes for additional questions. Go ahead and type into the chat box. Some people are typing. Oh, sorry, I just noticed a question, 2 questions that someone asked. So one is about TENS and stimulators. So there's really no evidence base behind this, and especially the implantable stimulators. There are pain clinics that basically most of what they do or much of what they do is implant these stimulators, but there's no evidence for them. And, you know, I think we've all seen patients who have had these stimulators who have had horrible infections, and so these are things I really would not recommend. Neuropathic pain. So I kind of glossed over the non-opioid pharmacologic therapies, but so the evidence base for gabapentin for neuropathic pain is probably strongest for diabetic neuropathy. For HIV, actually, the main study was a negative study, and there's also a study of Lyrica, or pregabalin, I should say, in people with HIV. There was also a negative study. We use a lot. I would just be careful of the dose. So studies, especially studies that have looked at combining opioids and gabapentinoids, have found that once you get over 900 milligrams of gabapentin, it really increases the rate of mortality. And 900 milligrams of gabapentin is more or less a starting dose. That's 300 milligrams TID. So I wouldn't, you know, start and then push on the dose. You know, I think after you get to 900 or a little bit more, really assessing those risks and benefits and trying to understand from the patient, like, is this actually really helping? And if it's helping, that's great. But if it's not helping, more is not likely better. Other questions? And I guess other options for neuropathic pain while I'm on that topic. Sorry, I guess I didn't fully answer that question. So duloxetine can be helpful for neuropathic pain. It's not been specifically studied in HIV, but that's another potential. Topical capsaicin, I've almost never seen anybody use it successfully. It's so difficult to use because it can be so painful. But there is actually evidence for that. And then cognitive behavioral therapy actually for neuropathic pain. You know, even though, regardless of what the source of pain is, some of these same self-management and cognitive strategies seem to work. And so trying that can be really helpful. And then being really certain to carefully address any other mood-related comorbidities that could be making the neuropathic pain worse. Bupropion so somebody's asking the question, any specific thoughts on bupropion for peripheral neuropathy? I'm not sure exactly. Do you mean, I'm just curious if you mean buprenorphine rather than bupropion. bupropion. But for bupropion, I don't have any specific thoughts other than it's important to treat people's mood. You know, and we could think about, that's not usually the first antidepressant that I reach for, but, you know, if that's worked for somebody in the past or something, that seems like that makes sense. If you meant buprenorphine, then you know, again, I try to avoid opioids for any type of chronic pain just because we know the evidence base is so poor. And if somebody's already on opioids, then I do the things I mentioned about kind of considering tapering them or switching them to buprenorphine. I hope that answers your question. What about compounded topicals? Right. This comes up sometimes. If you have a pharmacy that can compound ketamine, lidocaine, et cetera, you can try it. Again, there's no evidence base, so it's kind of a shot in the dark. But if you have a really good compounding pharmacy, I've certainly done that from time to time. But there's not a lot of there's really no guidance out there that I'm aware of about it. Other questions? I see somebody's typing something. Do you offer acupuncture? So I personally do not, but we have a group in our medical center that does, and so I refer people there. And actually, so our UPMC is a health system and also an insurance plan, and our insurance plan actually covers, I think it's 6 sessions of acupuncture for low back pain, so we refer to them often for that. But you know, if it's not covered by insurance, it could, you know, for us it's usually like $80 a session, so it can be really expensive. But it's definitely, there's a good systematic review that's a few years old now, but on chronic pain and acupuncture, and it looks like acupuncture is better than sham acupuncture, and sham acupuncture is better than placebo. So it's probably mediated to some degree by placebo effect, but not entirely. And so, and it's the risk is financial. So that's something that somebody can decide whether that financial burden is worth it to them if insurance doesn't cover it. What else? 82 of you are still on the line, so I'm thinking people may have other questions that they're waiting for somebody else to ask or something. But I'm hoping people will feel free to ask questions. Lidocaine patches. This is a really good question. So this makes me think I probably should have spent more time on the non-opioid pharmacologic therapies part. Oftentimes people are less interested in that, but I'm glad people are interested in this. So in the U.S., lidocaine patches are only FDA approved for post-herpetic neuralgia. So in my experience, lidocaine patches can be helpful for, you know, like if lidocaine patches can be helpful for low back pain, for knee OA, et cetera, anecdotally. It's very difficult to get them paid for. Sometimes insurance will pay for them, but most of the time it won't, and that's usually the rate limiting step. There are over-the-counter formulations of lidocaine, so I just tell people ask the pharmacist for the highest potency over-the-counter one. Otherwise, if you prescribe them and they're not covered by insurance, they're absurdly expensive, and that's usually the barrier. Glad to hear this has been helpful. Thank you, Terrence. Your questions have been excellent. I appreciate your participation. Other questions? recommended. Yeah, that's a really, yeah. So in trials of capsaicin, so Terrence is saying that he has recommended lidocaine before capsaicin. I do the same thing. In trials of capsaicin, what they actually do is pre-medicate with lidocaine and allow PRN opioids. Definitely would not go down the opioid route, but agree that topical lidocaine and then capsaicin is something that I sometimes recommend. I've only ever had one person who I really feel like has been truly successful with that, but it's definitely something to offer. It's just, I think, hard for people to do it. And then, you know, I always tell people, like, don't put your fingers in your eyes, you know, like, just be careful, you know, that kind of thing. So I think, oh, yeah, compression stockings for severe, I'm assuming you mean peripheral neuropathy. Yeah. That makes sense. And I think I've answered most of the pre-registration questions. How does one incorporate this into a specialty clinic? How does one, actually, I'm sorry, when you moved it, oh, there you go. How does one incorporate this into a specialty clinic? I use the box of specialty infectious diseases. I'm not 100% sure what's being asked there. I mean, I think, you know, regardless of the setting you work in, there are probably people who are available that you work with who have skills that would lend themselves to addressing chronic pain. So social workers who are trained in motivational interviewing, pharmacists who, you know, really understand how to educate patients about medication safety, and are excellent at helping to pick an antidepressant for somebody based on their prior experience or what have you. So just thinking about the resources that you have within your clinic, and then, you know, like I said, we actually have a physical therapist, and it was not easy to get this to happen, but we actually have a physical therapist that works with me in clinic. But if you don't have that, you know, finding a local physical therapist that's very pain-friendly, that you can refer to and who can give you feedback. Yeah, physical therapy is very helpful. I agree. So there's a comment about that. There's the best evidence for it is in low back pain, but, you know, any kind of sort of focal musculoskeletal pain, we have a wonderful physical therapist that we use that's in our clinic. Yeah, so somebody's commenting that trauma is a really important historical factor for a lot of people with HIV. Trauma is highly also associated with development of chronic pain. So this person is saying, please discuss somatic symptom disorder from a psychological viewpoint. Discuss somatic symptoms. So I'm not 100% sure what's meant by that, but I will say that, you know, somatic symptoms are really common in people with chronic pain, and a lot of times these are people with multi-site pain who kind of, you know, if you really press it, they really meet diagnostic criteria for fibromyalgia. Most of my patients have a lot of somatic symptoms, have multiple pain complaints, and if you go through the diagnostic criteria for fibromyalgia, they meet them. And so, you know, the treatment for fibromyalgia or even for chronic widespread pain without all the somatic symptoms necessary for fibromyalgia is, you know, treating mood. Duloxetine is approved in the U.S., can be effective, cognitive behavioral therapy. I'm finding that neuroreferrals have not been any more helpful than treating peripheral neuropathy, pain, and primary care. Yeah, I mean, so to diagnose peripheral neuropathy, right, it's just a clinical diagnosis. So as long as they have, you know, numbness and tingling in their hands and or feet, and they have HIV, which they do if they're in your clinic, then, you know, the recommendation is just to say that's peripheral neuropathy. They don't need any additional testing. Where I've referred people to neurology is where I have people for whom I'm unclear on the diagnosis. So, you know, maybe it's really unilateral, or it's hands much more than feet, or something that doesn't seem totally consistent. And so I want to get an EMG nerve conduction study just to make sure that I'm not missing something different. But I agree. Neurologists don't have any other magic treatments than what I described. So they're in the same boat as we are. Somebody says, I work in a prison. I'm unable to prescribe opioids. How can I treat chronic pain effectively? I really hope I've answered that. What recommendations can you give for someone with alcohol? And I think there's more to this question because and on I'm assuming you're going to say naltrexone, but we'll see. Oh, peripheral neuropathy. For alcohol neuropathy, I see. The question is, what recommendations can you give for somebody with, so peripheral neuropathy treatment is more or less the same across the board. So it's gabapentinoids, TCAs, topicals, and sometimes people will use other anticonvulsants, but they're really not, like valproic acid, et cetera, those are really not generally recommended because there really is no evidence behind them, and cognitive behavioral therapy. And then, of course, discontinuation of whatever the initial, so treatment for alcohol use disorder if the person is still actively drinking, blood sugar control, somebody's diabetic, et cetera, treating comorbid mood disorders. Yeah, we don't have super easy solutions for chronic pain, and most patients recognize that too. I often hear people voice that frustration, and I share that frustration. If I had I always tell people, if I had a pill that would fix this for you, I'm not holding out on you, I would give it to you. You're my favorite patient, I promise. You'd be the first one I'd give it to if I had something like that, but there just isn't. So here are the things we do have. Oh, good. I'm glad it's been helpful. Thank you. What other questions do folks have? So 67 folks hanging in there. Thank you. Appreciate that. Thank you. I'm glad it's been helpful. So a lot of content to cover in a short period of time. So I'm glad it's been helpful. Great. All right. Sure, no problem. Thank you for your engagement. All right. Yeah, peripheral neuropathy would be great as a separate topic. I agree. Can put our vote in for that. All right. Thank you very much, everyone. We really appreciate your engagement. And great. Thank you. Glad it's helpful. Great. Great. Thank you. Great. Yeah, and please feel free in your feedback to let us know what you'd like more of or less of. And don't forget to come to our cannabis talk. Is it possible to get the slides? Jose, can we get people the slides? Okay, great. So here's the next, thank you. Here are the upcoming webinars. So the cannabis one is Tuesday, October 6th. And in terms of getting the slides, Jose, do you know if we can get people the slides? I'm assuming we can.
Yes, the on-demand version of this webinar along with the picture presentations will be available on the IAS-USA website within the next 24 hours.
Yeah. And somebody is saying that the topic deserves more discussion, maybe in a series. This is actually the first of a 4-part series, so we're with you on that one. Part 2 is cannabis. Part 3 is opioid use disorder treatment, essentially, and the 4th one is mental illness and pain. So there will be more. So please attend. Great. All right, everybody, I think that's it. Everybody take care. Stay safe out there. Thank you very much.
Thank you, Dr. Merlin. As a reminder to our audience, Evaluation and information on how to claim CME will be emailed tomorrow by 5 p.m. Pacific time, and this will enable us enough time to review those that have attended today's live broadcast. Again, upcoming webinars will be available on the IAS-USA website and are open for registration. And the 3 remaining parts of this series are listed. Upcoming COVID-19 dialogues and how to sign up is available on the IAS-USA website. The next dialogue will be next week, and it will be including Dr. Landovitz and Dr. Overton. We would like for you to save a date for our National IAS-USA Virtual Update course on HIV management, which will be on Thursday, November 12th. More information will be available on our website. Lastly, we would like to thank our presenter, Dr. Merlin, to the audience for your engaging participation, and to all HIV clinicians working 24/7 in the era of COVID-19. This concludes